Right. So we're going to go ahead and get started. So first, let me just say thank you so much for everyone that has come out tonight to join us. This is the Xi Alpha Lambda chapter of Alpha Phi Alpha Fraternity Incorporated's ongoing health series, Onward and Upward. And tonight we're going to be dealing with mental health awareness because May is Mental Health Awareness Month. So again, thank you very much for joining us. I am Brother Dr. Benjamin Young. I'm going to be your host and moderator tonight. And I am also the Health Awareness Chair for our chapter. And it gives me great pleasure to introduce you to the panelists who are going to be enlightening us tonight. So without further ado, I'm going to go ahead and introduce them. So let's start off first with Dr. Adrienne Weaver. Just to give you a little bit of information about her, Dr. Weaver is a trauma trained clinician, licensed clinical social worker, professor, consultant, and speaker. She specializes in trauma, anxiety, relationships, identity development, and culturally responsive care for children, adults, and couples and families. Her research focuses on Black women's experiences, trauma, leadership, and campus sexual assault policies at HBCUs. She is also the founder of Changing the Narrative Consulting, where she supports organizations and leaders in creating trauma informed and empathic environments. Dr. Weaver is also a proud member of Delta Sigma Theta Sorority Incorporated. Thank you, Dr. Weaver, very much for joining us tonight. We appreciate your presence. And then next, we have Mr. Maurice Spence. Mr. Maurice Spence is a registered nurse with over 14 years of experience in hospitals in Florida, North Carolina, and Tennessee, and in a variety of nursing roles. Pertinent to tonight's talk, he served as a house supervisor at an 80-bed acute inpatient mental health facility and currently works at an inpatient psychiatric hospital in North Carolina, which focuses on active duty military, veterans, and first responders who are experiencing psychiatric challenges. He is a proud member of Alpha Phi Alpha Fraternity Incorporated. So thank you so very much, Brother Spence, for being here tonight. We appreciate your presence. Oops. And then next we have Miss Demetra Chandler. She is a licensed clinical social worker, clinical supervisor, substance abuse specialist, and behavioral health leader, currently serving as the clinical director of substance abuse treatment in a substance abuse treatment facility in Fairfax, Virginia. She has extensive experience working in medical social work, community services boards, military and veteran populations, children and families, crisis intervention, and community mental health settings. Her clinical background includes working with trauma, anxiety, depression, eating disorders, behavioral disorders, suicide prevention, crisis management, and co occurring mental health and substance use disorders. In addition to her clinical leadership, she has owned and operated two private practices and founded a nonprofit organization focused on mentoring and developing young Black clinicians while providing free mental health resources to underserved and marginalized communities. Thank you so very much, Ms. Chandler, for joining us tonight. We appreciate your presence. And then lastly, but certainly not least, we have Mr. Watson Louisdor. He is a licensed professional and mental health counselor. He owns A Better Tomorrow Counseling and Consulting LLC and has worked at the county, state, and federal level in mental health. His area of specialty is mental health and substance abuse. He also recently launched a YouTube channel called Watz, the Black Therapist. And it's Watts, W-A-T-Z, short for Watson, his name. But again, Watts, the Black Therapist, and it can actually be found on Instagram, TikTok, and Facebook under the same handle. He is also a proud member of Alpha Phi Alpha Fraternity Incorporated. So, Brother Louis Dor, thank you so very much for joining us tonight. We appreciate your presence as well. And now I just want to establish a few ground rules of how we hope to be able to conduct things tonight. As far as the forum is concerned, it's really going to be Ask the Expert. So you will have a chance to ask questions that you may have of any of our experts, general questions or specific questions based on some of their areas of specialty. And because we realize that sometimes conversation needs to be stimulated a little bit, I have actually had them submit some questions to me, kind of vetted on their own experience, that I will be using as well to kind of get the conversation going. But we will certainly plan to leave some time for you to ask questions also. Our goal is to have this last for an hour, hour and a half max. So by 8 o'clock, we should be out. And so, with that being said, we want to make sure that everyone gets a chance to be able to participate as much as possible. So, I would certainly just ask that everyone on both sides, both those who are asking questions and those who are giving the answers, consider brevity in order to allow everyone to be able to participate. With that being said, we're going to ask that you submit any questions that you have via the Q&A feature. So you should be able to find on your screen three dots. And if you click on those dots, and usually it says more, if you click on those dots, it will then lead you to different features that are available within Zoom. One of those is Q&A. So you are welcome to use that to submit your questions. And we will be monitoring that throughout the forum in order to start asking those questions of our panelists. The chat feature will still be available, and you can use that for just general commentary. And if for whatever reason we're having trouble with the Q&A feature, then we will go to the chat feature to submit our questions, but we will announce that if that happens. So for now, again, just keep in mind to use the Q&A feature for any questions that you have. And this is intended to be a safe space. So please just be courteous to each other. And, it's hard to be vulnerable in front of strangers. It's certainly hard to be vulnerable about issues surrounding mental health, but we want to make sure that we create a safe space for everyone involved tonight. So just keep that in mind to be respectful of each other. And you should also know that this session is being recorded. The goal of that is not to violate your privacy. It's more so to be able to use this for educational purposes later. So just be aware of that. And then lastly, let's increase our awareness of mental health issues. Again, May is Mental Health Awareness Month, so it's just appropriate, obviously, to be able to jump into this. And I thought that one way to catapult this conversation would be to actually talk a little bit about all these different letters, because I think that in an effort to have more awareness about mental health, it's important to understand that there are lots of different healthcare providers and mental health care providers. And yet it could be a little bit confusing as to who they are, how they are different from one another. So, in a very superficial way, I thought that it would be nice to kind of just talk about some of these things. So, social workers, you might see LCSW associated with their name, their professional title, and that stands for Licensed Clinical Social Worker. We actually have two social workers on our panel tonight. And so, social workers are some of the individuals who can help and provide mental health care or therapy. Professional counselors also do this. You will sometimes see LPC with their name, licensed professional counselor, or LMHC, licensed mental health counselor. And both of these professionals can provide care for mental health issues. I think that one way, again, very superficially, to try to differentiate them is that social workers have the social resources that are a part of their training and their experience. And so sometimes their mental health therapy or treatment can be contextualized for the folks who may additionally have, housing needs, or may have, childcare needs, or other things that perhaps go hand in hand with some of the mental health issues that they're dealing with. But both of these are people who can provide mental health care for whatever issues you may have. Marriage and family therapists kind of goes along with the name. They tend to focus on those demographics, those who are married and those who may need have needs with regard to their family. Psychologists have doctorate degrees, and they can be various ones. And so you have PhD, Psych D, sometimes even educational doctorates. But these are individuals who very often are involved with testing with regards to psychological diagnoses and treatment. And so, for example, these are some of the people who might be helpful in diagnosing people who, for example, need gifted classes and might need individual education plans. Sometimes psychologists are actually involved in doing that. And also testing with regards to, again, specific psychological diagnoses. They can also offer therapy and treatment, and sometimes that may be coupled with specific kinds of therapy, like cognitive behavioral therapy or psychodynamic therapy. And so, again, just a different kind of provider, and sometimes with a specific focus. And then psychiatrists and psychiatric nurse practitioners. These are people who are more on the medical and specifically medicine side of the psychiatric disorders or the mental health issues. And so these are typically MD or DO. medical doctors, or nurse practitioners. And so these are people who are specifically also going to be managing medications with regards to the different mental health issues you may be experiencing. And they can often work in concert with some of these other providers since they're the ones that actually prescribe medications. So again, just on a very superficial level, a way to be able to distinguish some of the different mental health care providers. And hopefully, as a result of your experience tonight, you'll get a chance to learn some more about different kinds of providers and how they can be helpful. So with that, I can actually stop sharing my screen. And I now want to take this opportunity to start asking some of our experts some questions. So you feel free to start using the Q&A feature now. And as I said, we'll be checking that over the course of the forum to be able to introduce your questions as well. So let's start with Ms. Demetra Chandler first. So how can you tell the difference between normal stress and an actual mental health condition?
Yes, for some reason I feel like I knew you were going to pick me.
Mm.
But yes, good question. So stress is something everyone deals with in their daily life when it comes to parenting, work stress, and even simple as just maybe driving or just our day-to-day daily needs when it comes to just taking care of the household or things like that. And that's normal stress, or even just different life changes that we might go through. And that stress typically can get better over time when our situation gets better over time or when we're practicing healthy coping skills. And what I mean by coping skills is like running or exercising. I say running because I like running. But exercising or journaling or anything that we typically like to do that's healthy, that makes us feel good. And stress is supposed to typically get better over time when the situation gets better. It starts to look more of a mental health condition when the stress and symptoms starts to intense and it's lasting longer. So looking, for example, it might start turning into anxiety or depression. And the biggest warning sign is interfering with our daily functioning. So it's hard for you to get up in the morning, you're isolating, you're not motivated anymore, you might not be able to go to work. And again, I'm not saying that even a mental health condition can't be improved after a period of time, but just those differences there is when it starts becoming more intense, long lasting, and it's interfering with your daily functioning on a daily basis. So yeah.
Got it. Thank you. It sounds like, a consistency of problems, and then, like you said, really starting to interfere with your ability to function.
Right.
That's where, may be becoming more of a serious issue.
Yes,
Fair? Okay. All right.
absolutely.
Thank you.
Mhm.
All right. And then let's see here. How about Brother Watson? Um, I think that, particularly in the Black community, but I think that this is just an issue for a lot of people. It seems to be difficult sometimes to be able to reconcile religion and mental health and health in general. We find ourselves sometimes at a crossroads when it comes to those two things. I was hoping you could speak a little bit to, how you have come across that in your profession, and do you find that people struggle with even bringing up their religion when it comes to talking about their mental health? Is that an appropriate place to deal with both?
Yes, with and I find that in my practice that a lot of clients bring their religion to the table, and I welcome that because in our code of ethics, as long as I don't push my religion on someone else, I can help a client get through some of the challenges that they may have, probably within the church or just mental health in general. But I usually incorporate it in treatment if the client is a religious person, whatever that religion may be, whether they be Muslim, Jewish, Catholic, whatever the religious denomination is. I find that it's very helpful in treatment to incorporate it because it adds another protective factor, which as a therapist, I like protective factors are factors that people bring to the table that make them more functioning and less likely to engage in suicidal behavior. But but it also just gives them a brighter side of things. And whenever you bring religion to the table, I'm more than welcome to, I'm more than happy to help a client through that, because a lot of times clients may think that they can't talk about religion in therapy. And I always welcome that. And I'm glad that I'm also a Christian and I'm a member of a church, and I'm glad that my pastor embraces it and incorporates it in church as well. Like anytime that anybody needs some kind of services in church, he encourages it. So I definitely encourage both sides to it whenever clients come to sessions.
All right. Thank you. Appreciate that. Let's see, Brother Spence. You represent an interesting perspective in this panel because you work on the inpatient side. And I think that that is a part of mental health that many people have either not experienced or are quite frankly afraid of. And probably even try their best to avoid. And yet, I think if some of us were to be transparent, we would have to admit to the fact that we have loved ones who have sometimes had to be hospitalized for psychiatric care, if not ourselves. And so I was hoping that you could speak to a specific thing that comes up sometimes, which is what is an involuntary commitment?
Yeah, sure. And thank you for the opportunity, Brother Young. I would like to so there's two main things. There's voluntary commitments and involuntary commitments. And you got to remember, state laws vary from state to state and what the threshold is. But in general terms, voluntary commitment is when a person decides to take themselves into a mental health hospital or seek mental health to a mental health provider and and ask for that help. When we talk about commitment, we're actually talking about being an inpatient person, being hospitalized, being having to spend a night just like you would spend a night in a medically based acute care hospital in the community. The difference is being involuntary is that now you're putting a legal what I mean legal, a non-criminal, but a legal structure within that hospitalization, meaning that the provider, i.e., the medical provider, which is the psychiatrist or most times nurse practitioners as well, they in essence commit. And or some, if I'm not mistaken, there are some licensed clinical social workers as well too. They actually sign a document, and it varies from state to state. It's called different things. In Florida, it's called the Baker Act, and in different places, it's called different things. But in essence, it's a legal document saying that this person has to stay in the hospital until a licensed person clears them or allows them to go. Now, different states, it gives a turnaround time and when that this person has to, in essence, go to the court system in order to reevaluate that order. Because if you want to think about it, nobody wants to be in a hospital, first of all. And secondly, when you're basically against your will, because you're in essence taking away some human right because the person cannot leave until the licensed provider releases them. So yes, there is a legal veil, but it's a medical, it's a commingling of medical and legal veil. And I want everybody to remember this. This doesn't have anything to do with criminal. Okay. This just purely protective of the individual, where their rights to actually leave is removed for a temporary period of time.
Great. Thank you very much for that insight. I see that we do have some questions on the Q&A, so I've made note of those. We'll definitely circle back to those. I wanted to ask Dr. Weaver a question too. Dr. Weaver, when allegations emerge against someone admired in the community, how do friends reconcile the person they thought they knew with the accusations that are being made?
So, first, thank you all for this opportunity and good evening, everyone. When community figures, our friends, our family, when they face serious allegations, what it does is it triggers a painful psychological phenomena, and that is known as cognitive dissonance, right? So there is the discomfort of holding two contradictory beliefs at once, right? The human brain is generally binary. So we like to keep things as we see them, that, oh, it is just, black, white, there is no gray, there is nothing else, right? So then we fall into the good guy or the good gal fallacy. Right. So then there is that. We want villains to always look and act like villains. It is so incredibly difficult to accept that someone can be a visionary leader, a generous friend, a licensed clinical social worker, even, and the perpetrator of harm. Both of those realities can exist simultaneously. There's also the idea of that we use defensiveness sometimes with self-preservation, because it's hard to reconcile that an accusation could mean that maybe my judgment of someone's character was flawed, or that they could exist outside of what they demonstrated to me. So if I could be deceived almost as someone, by someone very close to me, well, then it shatters sometimes our safety and our trust in community and people, because when people do things outside of what we know them to who we know them to be, when they act outside that way, it takes away the security blanket that we have, right? And then there's also been the process of reconciliation, right? So true reconciliation, it requires moving beyond denial, because we can't just be in denial that, well, I can't believe they would do this, or I can't believe that this happened. What needs to happen is that we have to center it's someone who doesn't make it out. The survivor is someone who has experienced a thing and is able to work through it. So it's important to center that person rather than protect the legacy of the accused, right? It means accepting that a person's public persona and contributions, that they don't erase or excuse their ability or the act of perpetrating private harm.
Gotcha. Thank you. That is that's a very profound way of thinking about that. I appreciate that insight. I want to take this opportunity to look at some of the Q and A. So one of these kind of goes back to the religious question. So certainly, Brother Louis Dore, but whomever else, feel free to jump in. Have you found someone's religious beliefs to be a challenge in resolving mental health issues?
I've, yeah, I have, because sometimes what I would recommend to a client in therapy may sometimes not align with what's in the Bible. So I typically try to ask the client, I give the client the option. I usually tell them, hey, this is what I would recommend on a mental health side, but if you feel a conviction to follow what the Bible tells you to do in this situation, I would definitely encourage you to do what you would like to do. Because my main goal as a therapist is to help guide a client through situations that they have challenges in, and not to impose what I feel like they should be doing or how they should be reacting to different religious convictions as it if it clashes with different mental health therapeutic things that we may do in sessions. So I typically allow the client to make that decision on which one they would want to pursue, and I would help guide them through it in that format.
Gotcha. Okay. Thank
I
you.
like to jump in.
Yeah, sure.
I do a little bit differently, because I have clients across all faiths and not. I have atheist clients, agnostic, and then I have some, everything is what the Lord said. And I think the Lord talked to them more than the red words in the Bible. So when I have some of those people, what I like to do is I like to kind of deconstruct some of what is the super spiritual to connect it back to um, their own decision making, their own, processes, because I love when someone comes in with the prophecy, because what the prophets keep saying is, and and I get that, and I'm like, well, people, if you're a believer, then you believe that they prophesy in part. So what you don't get is what the process is. So if I have to bring out some scripture and talk through that everyone had a process to go through before they got to the promise, that even the children of Israel had to go through a long process, right? Because they didn't do what they should have done from the beginning. So we talk about all those things. And if there's someone who, if they're just all set, well, God wouldn't do this, we bring in all the things that they may believe. And sometimes we have to do a little bit, of digging to help them understand that some things aren't punishment, that there are some things that no, the devil wasn't busy, dear, you were available, right? So we talk through all those things to make sure that we are getting to the base of what their issue is, and that I'm not allowing any excuses. And if there's an atheist, I have to put down some of what I believe. I'm church, I'm a preacher's kid, so I'm all things Jesus sometimes. Right. So I have to, sometimes not, I don't let that cloud how I deal with my clients, because everyone has self-determination to make their own decisions. So I believe that the pinnacle of my practice is meeting the client where they are. So wherever they are, I have to get to that space in order to help them get to where it is that.
Yeah, thank you. Appreciate the perspective. Another question that came up, and this would be to anyone. How do we as Black men overcome the stigma that therapy or mental health assistance is a sign of weakness, especially for men raised to always appear strong or to push through the pain or the stress?
I'll jump out on that one. With There's a lot of stigma associated with mental health when it deals with Black men, because we come from families where w- our parents typically tell us not to share any of our personal business that go on in our own household. So that kind of serves as a block, which makes it difficult sometimes when Black men want to come to a therapeutic session and talk about like real personal stuff that may happen in the family or outside the family. But that's what I've found, is that a lot of times, with that cultural difference, with where, sometimes the families don't want anybody to talk about stuff, it makes it difficult. And then also with the weakness part, we've always grown up in a certain situation where people feel like if you feel like you got to go talk to somebody, you may not be a strong individual, or you're just weak. And so there's a lot of stigma attached to it. But I'm glad that nowadays, especially with what happened during the pandemic, when so many people got exposed to how important mental health was to themselves, like being locked in their house all day during the pandemic. And I think more people are looking at it more on the therapeutic side and less on the weakness side, from just my perspective on the clients that I deal with.
I'll also like to
Yeah,
tackle that one.
yeah, please.
So I have the unique opportunity right now, and a unique pleasure and privilege to work in a unit that works with veterans, active duty military, um, law enforcement, and first responders. So first of all, right off the bat, we're talking about the strongest people that you are going to come across. So we can just discount that myth right off the bat. The second thing is that I can address from the acute end. What I mean by being acute, it means that a person seeking mental health help is in essence going to harm themselves soon, or is thinking about harming themselves, or their condition is so bad that their family members, loved ones are just extremely concerned. Maybe they're not maybe they haven't shown up to work for 2 or 3 days. Maybe they haven't taken a shower for a week, or just maybe they just haven't kept themselves up. And family sees that as signs to where people will need some help. So from the standpoint of signs of weakness, I see the contrary. I see it as actually a tremendous sign of strength. because strength, and not only strength, but also self-reflection. It takes a person who can reflect to themselves and says, "Hey, listen, I may need some help. This is not normal. I'm going to harm myself. I'm going to harm others. Let me seek help." On the other hand, when we initially talked about, that's my voluntary end of the first question that you asked me. The involuntary side is when another person sees you going down the going on the wrong route, and you don't see it, and they may call for law enforcement assistance, and law enforcement interacts with the patient and says, okay, maybe we need to go. This is not a criminal issue. Maybe we need to go into a psychiatric um, um, hospital against your will. So it comes from both sides, and it is more acute from the type of work that I do.
Yeah, thank you. We have another question here, and it says, as I unpack what Ms. Chandler said or shared about mental health, I was wondering how PTSD plays a role in this conversation. A lot of the details mentioned earlier seem very similar to symptoms of PTSD. Can you help clarify how they overlap or how they differ? And so, just as a reminder, the question that's being referred to there is, how can you tell the difference between normal stress and a mental health condition? And the question is, what role does PTSD play, I guess, in maybe blurring those lines? And how does one go about trying to unpack that?
Yeah, that's a good question. Some of the examples I gave does overlap with PTSD, and but where PTSD can definitely differ in the sense of the symptoms of how, especially with it being disorder, because sometimes you can just have post-traumatic symptoms, and then you can also have the disorder based off of um, insomnia, nightmares. And flashbacks, you're having night terrors. It's pretty more significant, your symptoms. And to the point where you're getting, and triggers are, because I was getting ready to say triggers, but just in case anyone doesn't know what triggers are, it's just something that typically starts internal or external feeling or emotions within you due to something that has happened to you. So maybe you walked into a room and you smell something that's related to something that triggered you before, that, or even like that made you vomit, or so I'm just trying to give an example of something that could trigger you, that maybe you ate something that didn't sit well with you, and so now every time you smell it, it triggers this uncomfortable nausea feeling in you. And so, but just to relate it back to like just post-traumatic stress and post-traumatic stress disorder, it becomes an intense, long-lasting traumatic symptoms, intense anxiety and stress. And it can differ from, depression, anger, fear, depending on, and everyone's different. So not everyone's post-traumatic stress symptoms or disorder might look the same. It can look different for everyone. But typically some of the symptoms are similar in the sense of when it comes to those night terrors or ongoing stress related symptoms. And again, the difference with that is the intensity, sorry, of it, and how long the symptoms are lasting, and what it looks like differ from just normal stress that we can cope with on a daily basis, and how it's interfering with our daily lives.
All right, thank you very much. I'm going to shift gears here. We have a question. How has social media exacerbated the decline of mental health amongst youth? What's the difference for adults? Anyone want to take a
Okay.
stab at that
Well,
one?
I mean, I can start there. Well, social
Okay.
media is absolutely, there are lots of studies that link negative uh, outcomes for teenagers, especially on social media. And I have lots of my younger client, my 20-something clients who are in that life transition from college or high school to college to early career. They think they're behind because of what they see on social media, right? So social media sometimes what it does is gives a snapshot of what the user wants everyone to believe, not necessarily, as it is. Right. So then when they see their friends, I always, um, dine out the bar or, in these fancy cars or they on trips. They're like, I look like I'm not doing as good as my friends. And I'm like, but what if they're home eating golf? I go to the extreme because sometimes I can't just keep it very simple. But I asked them, what don't you see behind the what's on your mind? So I have to say that even in adults, people get on social media and they lie, trying to keep up with what they think is happening, or and now we see the gifs and the memes that are like, I think one that tickles me all the time is like somebody like out laughing on a yacht or something. They're like, how you post when you just finished crying all night about that breakup last night, right? So there are a lot of times that people portray on social media what they want their lives to look. So everyone has to be mindful that, you know, no one is generally, married couples are posting the happy pictures. I tell people all the time, I love posting. Me and my husband look good in pics. I'd never post when I want to push him down the stairs. Duh. I mean, so, it's always, I always say you don't come and post. And lots of people, I'm like, get a journal. Some things aren't for our social media because there's some people who overshare on social media. Or then sometimes it can absolutely be a cry for help, right? So if I see someone that makes a post that, says something or alludes to the idea of self-harm or, some that I'm going to reach out right away. I'm like, hey, are you okay? Here's 988. That is the crisis line for, crisis individuals 24/7 trained to respond right away to someone who is having suicidal ideations or in a severe crisis. I may, just kind of reach out and check in. If I see those posts start looking a little bit different, I'm like, hey, you okay? Because some people, they bleed all on your timeline. I just, so it's a very interesting thing to sit and watch and to unpack. So I think that social media has absolutely, it can lead to a negative decline in mental health. And there's a really good Netflix documentary that I saw maybe it was during COVID, but where some people who escaped Facebook kind of talks about the algorithms and how they actually train those algorithms to make it addictive. And, and we all know now, I think I can mention something and I can have a phone conversation. The next thing I know, it's all my ads on Facebook or in social media sites. So even when you disable ad tracking and all the things, someone is listening in order to manipulate a market. So it's important to realize that that is how they were able to sway, parties used to sway elections and all things. So I think that, oh, absolutely, the dopamine hits that social media gives, it's better than any psychotropic med on the market. So you have to absolutely, if you have children and teenagers, monitor what they're watching, have a check-in about what they're thinking about, especially now with AI becoming people's friends and, uh, therapists in some cases. It's really important to check in with those, the most vulnerable, as it pertains to social media.
If I can
That is
add to
a,
that,
oh, please go ahead. Yeah.
I just recently did a presentation where it talked about mental health in Black men. And one of the researches that I did for that presentation was social media. And something that came up during my research, it was that it showed that young Black men are 6 times more likely to suffer from anxiety and depression based on the materials that they get online. So and it's kind of like what she was talking about, like the algorithm and all that stuff. So as soon as you see like one negative thing, you see another negative thing. So there's research that show that we're young Black men are more likely, 6 times more likely than their counterparts, like white counterparts, to deal with to have like depression and anxiety associated with social media, especially like during the pandemic when all we kept seeing was police brutality, police, a lot of young men dying at the hands of law enforcement, even though it may have been a small portion of our population, but the media, social media pumped it out so much that if you're a young Black male and you're looking at someone that you can identify with and say, man, this guy looks just like me. And if it happens to him and he didn't do anything, this can happen to me. So from my research, it shows that it increases the anxiety and it also increases the depression level among young Black men, social media.
Yeah, that is all really good input. I think just as a parent, I find um, I'm scared of what social media can do. My kids are very young, so we're not at a point where they have social media accounts, but it definitely affects how I think about it in the future as they get older and more of their friends have these things of what they would be exposed to. Because I see what you're talking about there with that sort of the skewed perspective that you get of what's right and what's wrong in the world and how that could affect how you feel about things, particularly as someone that comes from a marginalized community. Dr. Weaver, you made a great segue actually for another question that came up, which is how do you leverage artificial intelligence in your work? Have any of you found have any of you found space for AI in your work, or I guess maybe are you finding that AI is I guess kind of to what you alluded to, Dr. Weaver, sort of trying to take the place of like an educated and experienced therapist. I'm just curious, what have you been hearing from clients, and what are you seeing being brought to the table in that regard?
Well, for me, as far as AI, I use AI regularly as a tool. So in my private practice, AI summarizes my notes. Now, and just like AI does for everything else, it sometimes hallucinates or it gives something totally different. So you have to go in again, just say, "Oh yeah, AI got it," But it absolutely it has increased my efficiency, and it makes any clinician. I mean, Miss Chandler can probably tell you. Listen, notes.
I'm like this. Like I use AI. It makes our job
It makes it so much. It
20
makes
times
it so
easier.
much, so
The,
20
no- the
times
amount
easier.
of
I hate doing notes.
yeah, me too.
So I think it's the notes. And then as a professor of social work, I teach master's level social work students, doctoral social work students, and doctoral students in higher education leadership. And I've had to use AI and of course to detect, what's happening with their papers. And sometimes I use AI to help um, enhance assignments, so there may be something that I'm thinking, I was like, I think I need something a little bit different. So I may drop in my idea and say, yeah, but make this more appropriate for, this level of doctoral student or master's level student. So, I mean, I use it to help enhance, and I also educate my students on how to use it as a tool, and that AI should not be thinking for you, but you can use it to help correct grammar or even to create an outline. You can use it to help you create a shell of something, but it should not be formulating papers, because there have been times where I'm I check references. So I may want to read an article and I was like, this article's nowhere to be found because it doesn't exist, because AI made it up. So, it has its pluses and pros and cons, minus the environmental, the things that we're concerned about with data centers. So while it can be absolutely positive, I also recognize that there can be a lot of negative associated with it as well.
I was just going to piggyback off of you real quick, Dr. Weaver, and just saying, yes, with the notes, it can be helpful. But as clinical professionals, I think in every single professional field, being mindful of us proofreading, because like AI can be hallucinating and make up things that it thought we said. And now you have a client or patient's chart incorrect or wrong. Now you have someone else's information in there. And when we get audits by insurance, because it has happened in insurance companies and things like that, they see it and they're like, "Hey, your clinician sat here and wrote this, and it's completely wrong." The also thing that makes me worry too is when you do have these up and going new clinicians coming in, and now this is all they know, and they don't actually know how to write clinical notes. It makes me feel good that I know how to write clinically before I started to use this, but it's definitely training, like Dr. Weaver said, being mindful, even with them using that, they still know how to use clinical jargon themselves and know how to write, a note for patients.
All right. Well, then let's see here. We have, in all of your professional opinions, what are some evidence based therapeutic approaches or treatment models that have proven most effective when working with patients who may have distrust of the healthcare system or prior negative experiences with therapy?
I think I will say I don't know that I use any one evidence-based treatment model to overcome that because I don't know that I've had that as an issue someone came to therapy with. That may have been an issue that led them to me as a therapist. But for anyone who's experienced some sort of trauma, I am an EMDR trained clinician, which is eye movement desensitization and reprocessing therapy, which was headed by Dr. Francine Shapiro in order to address PTSD in veterans, but we use it in lots of other areas for people who are able to kind of follow the things that go along, all the processes that go along with EMDR. I may use something like that to help them kind of get past, serious issues, sometimes acute issues, but most times for me, what I have found that has been effective in helping one have a better experience in therapy is to be the therapist that I need. So I have, it's about establishing rapport, it's about staying present and about having a real conversation because, I say just like relationships, I always ask people when they say, I don't really trust therapy or I have bad experiences. I ask, are they partnered or in relationship? I say, how many was your partner the one you met when you first started dating? And has it been, is this the only person that you dated? Is this the only job that you've worked? Because generally when we have negative experiences, we move on, right? We find different jobs. We leave relationships that aren't serving us. And I say it's the same way with your relationship with your clinician. And that I always encourage persons to interview clinicians, talk to, build a rapport, get that consult, some people, everybody lives off vibes now, see what the vibe is when you meet a new clinician and, have a conversation because with your clinician, I tell people all the time, don't waste my time and don't waste yours. If you can't come to me and tell me everything you think about, I love when a client says, I know that's probably TMI. I was like, in therapy? Never. I'm like, you come in and you talk to me and you're going to tell me your deepest, darkest secrets, and we're going to uncover and we're going to rediscover who you are, and we're going to work past all those adverse childhood experiences. You should trust me. Well, this should be, one of your most important relationships is the one that you should be able to have, professionally with your therapist. So I always like to tell people that I look to listen more than I speak, but I tell my clients all the time I use myself where appropriate. And I'm a storyteller, so I'm gonna bring it back with us. I'm a preacher's kid, so I'm gonna have a small story for you to help, bring it together. And my clients are, I think for a long time I had a very large um, Black woman population, but I have a lot more white clients now. I was very surprised. Like, and they come to me, they're like, oh my God, what I've been looking for. And I have some who, they're real cute and they're like, let me give you the tea, Dr. Weaver. And I'm like, here we go. So I mean, but it's fun. But I'm glad that they feel comfortable enough to me to actually just be. And that's the environment that I say, the best way to help one overcome a bad therapeutic experience is to be a better therapist than they've had before.
If I could jump out a little bit, the technique I typically or the model that I usually like using is something that's called REBT, Rational Emotive Behavioral Therapy. And it's basically whenever they have like trust issues, I try to get them to challenge that because if once they start challenging it, they'll see that a lot of the stuff that they may have thought that they had trust issues with, but when they go deeper by challenging those different thoughts that they have, they'll see when they challenge the thoughts, it'll change the behavior and it'll also change their mood and everything. So it's just a matter of whenever they come in with trust issues, I just try to get them to challenge it and to try to use some reality therapy and say, okay, does this really make sense versus what you're thinking versus what's in reality? And then a lot of times, sometimes in our mind, something may seem like it makes sense, but when we talk about it out loud, then sometimes we're like, oh, that don't make sense at all. But in our mind, it made a lot of sense. But as soon as you start talking about it out in the open, then you get to challenge what you were thinking in your mind. And then sometimes it's able to help them get through some of that trust issues. For me, that's what I've found with the experience I've worked with.
Excellent. I have a question here that came from the chat. I'm going to go ahead and read this out just as a reminder for those who might be coming in later. We're using the Q&A function, but the chat is just for general commentary, but we're trying to look at both. But this one says, as a medical provider who does not specialize in mental health, I see a lot of patients with anxiety, ADHD, PTSD, and occasionally depression who use marijuana to calm or control their symptoms. Marijuana is somewhat associated with depression. What advice do you give your patients who use marijuana to help their symptoms? And as a medical provider, how strongly should I encourage people to not use marijuana because of the association with depression, or at all, should I?
I'm gonna jump in. That's a
Mhm.
hard one. So,
Mhm.
because marijuana is like I'm gonna say like alcohol in the sense of it's become normalized. Like alcohol is so hard to be looked at as a drug or an issue because it's everywhere and people are always drinking. Marijuana has now, I mean, it's legal in a lot of places and it's looked at as normal. To be honest, being a substance abuse specialist and working in a substance abuse facility with patients who struggle with alcohol, or maybe even with other drugs, and they use marijuana and alcohol as they're like, oh, that's not, that's not my drug of choice. That's not an issue for me. Everybody does it. I have a patient now that challenges me. It's like, you drink, right? Like, as you know, because it's normal. But everybody's normal. It's not everyone else's normal. That comparison and how our brain works is different. And when it comes to marijuana, I would encourage them, just like any other drug, not to, in the sense of it's a gateway drug. That drug can also lead to, using heavier drugs to cope with the depression. And typically, if it is getting worse or anything like that, when it starts to become an issue is when if noticing if they're trying to use more to feel the effect. And so I do still encourage them to try to find other coping skills, but even with Dr. Weaver saying always wanting to meet the patients and the clients where they're at the same time. And so if that's something that they're, I don't even know how to say, like using it in a safe way, because also coming from a harm reduction approach, which is if someone is going to use, how do we help them use in a safe way? So we're not like making them feel bad or belittling them or anything like that, but meeting them where they're at. So if they're using, how can I that approach is just a harm reduction approach in the sense of, well, maybe I'm giving them resources and they're using with other people. Maybe I'm with them while they're using, are there other with other friends or family members while they're using, and but also working with them on healthier coping skills or just different things that can kind of give them the same effect that marijuana is giving them. So I still would encourage them to try to do other things just because it is a gateway drug. Hope
Can
that
I
makes
Well, for
jump out?
me, oh, go
Oh,
ahead.
go ahead.
Yeah.
I, I don't normally, I do ask just for my own, assessment if clients and the ones who are regular cannabis users, they'll say. So, I like to ask how much they're smoking, is it to cope? What is their mechanism? Where do they get it from? I was like, listen, I'm not calling the police. I'm just asking, do you have a medical marijuana card or are you buying it from the guy, someone? So I just always like just to assess if they're safe because, in low levels and low, dosage amounts, there are some people who report having, better experiences, lessening their anxiety symptoms. But I also know that THC in higher concentrations can cause paranoia and other psychotropic um, issues. Don't ask me how I know. So I think so there's absolutely, I like to tell, especially young clients, I was like, listen, you have to be mindful, when you do this, that there are some other dangers associated with it. But even though I know everyone's doing it, it's legal in some states. I don't give medical advice, but I always say just make sure that you're using it, as responsible as you can be. But I always, I mean, I'm licensed in 5 states, and I think in a few of them, at least one of them is recreational use is okay. So I always, I just like to tell clients to at least if you're going to use, consider, going to a dispensary and going through the process to at least talk to the pharmacist who's employed there to, kind of use it in a way that is therapeutic versus just, smoking all day to numb whatever they're trying to numb.
I'm licensed in Florida and Georgia. In Florida, it's legal on the medical side, not the recreational side. So from my standpoint, because I work in the criminal justice system, so I do a lot of substance abuse assessments, mental health assessments, and something that I found because I remember when I first started, I've been doing this for about 19 years. When I first got into the profession, a lot of people used to get arrested for marijuana. So I'm just glad now that at least in Florida, they could get the medicinal marijuana card because I deal with a lot of clients that are on probation and that they used to go in and out of prison all the time or jail all the time because of violation of probation related to marijuana use. And a lot of them, and nowadays what I've seen that's really interesting is that as soon as the guy gets in trouble, within a month he gets on the he gets a medicinal marijuana card, but they may have like mental health issues like depression, anxiety, and it could have like those kind of effects on people, like what was being said earlier, like it can like really create more paranoia than anything else. But I found from a criminal justice side, it helps with not criminalizing a lot of the clients that I used to deal with that used to just violate probation just for smoking marijuana, and it stays in your system for 30 days. And so, on my standpoint, I usually try to encourage it if they're on probation and they don't have any major substance abuse history with like it being like a gateway towards something bigger for them. But if they don't have like no major substance abuse history and then they have a medical provider that wants to give them that medicinal marijuana card, I usually encourage it as long as so that they can avoid going into the criminal justice system if it will help them stay in complete probation without having to violate.
Okay. Thank you guys very much. Another question that's come up is Black Americans are more likely to be uninsured or underinsured. How does the mental health system address someone who needs culturally affirming care but can't afford out-of-pocket therapy rates?
I will say that there are not a lot of there are a, there are not a lot of things that the system does as a whole, but there are a lot of clinicians and practitioners who utilize resources, community resource community resources sometimes to help address that problem. So one of the organizations that I work with as a clinician is called the Center for the Equitable Access and Treatment of Trauma, and it is a nonprofit organization, and it's based in Miami, Florida. And what we did was we had a grant from the Carrie Meek Foundation where we were able to, our population was the uninsured, underinsured in Miami-Dade County who were either survivors of or witnesses of some type of gun violence. And of course, from there, it had to grow to just any type of trauma because we had lots of dollars in order to try and help fill in that gap. But one of the things, just as we talked about in the beginning, that the stigma associated with seeking mental health care, it is heavy in um, communities where there is high poverty. So we had a hard time actually getting participants because
Mm.
people were, anti-therapy, or they'll come to, therapy and they have three of their friends, it was all virtual. We were 100% telehealth, but they have friends there and they didn't want to comply, or they only wanted to come just for a minute, and they didn't want to follow through the program. So, you know, sometimes there are community health centers and other resources that will see uninsured or underinsured, but it's very difficult because those spaces usually have, long wait times, high burnout, high turnover of clinicians because they don't generally pay as well. So, because I was just doing this with another group of, Black women clinicians, it was a little bit different, but it's still very hard to sometimes overcome the stigma associated with mental health, especially in the Black community. So there are programs that exist, but it's still now there comes well, how do you get the people to actually want to come and get that help? Because, there's just a natural distrust with systems by lots of Black people for very good reasons.
I could jump out on that because I work in the criminal justice system. There is, even though someone may not have any money or may not be able to afford mental health counseling, culturally sensitive counseling, like with someone that's Black, or if they what I would like to tell our viewers tonight is that even though you may be seeking community mental health treatment in the community mental health provider, you can ask for a Black therapist, a male Black therapist, or a female Black therapist. It doesn't mean that, I mean, if they don't have it available, then they may not have it available, but you can ask, and if they have someone available, that will definitely help out on that end in terms of like not having money to be able to afford who you want to go to. But when you do go to places that um, deal with you, if you're like indigent or you don't have the money, they can if you ask, if they have it available, they'll make sure that they connect you with a Black female therapist or a Black male therapist if that's what you want. And sometimes those are the ones that are more culturally sensitive to your situation because they know your situation. But there's also our white counterparts that have gone through training and learn about their own biases that will help them treat Black folks as well. So, but I always encourage clients, like, if you want that kind of service, ask for it. I mean, nothing could go wrong with you asking. And if they don't have it, then just ask for somebody that's been culturally trained to understand what Black people go through so that you don't have to explain yourself so much in therapy sessions.
All right, we have this one here. We might have touched on this earlier. As someone who struggles with isolation and feeling alone and felt like they had nobody to talk to, where do you actually find your people? Was it online, therapy, church, gym, etc.? Where do you go to find those connections?
I think it just depends on the person and and the things that I think also, and if you're not sure, I think also trying different things, being able to feel comfortable, being uncomfortable. That's the only way that we can grow when we're uncomfortable. So I think just taking the time to step out and maybe trying different things or trying different hobbies that you normally haven't done before, and our support groups, depending on what you might be going through, to find those people that can probably relate to you or relate what's going on. And so I know for me, just being able to find a group of people to probably run with or work out, because that's something that I like to do. So if you focus on the things that do make you happy, that motivates you, that gets you out of there, especially if you're feeling lonely, that isolation, because that can be difficult, is finding just a good circle that's going to motivate you every day. And then I just encourage to try different things. I encourage to be uncomfortable, and to be able to work towards those feelings so that you can come out of it, and just doing different things to find different people to surround yourself with for support groups.
I think that it's one of those things where it can be a little bit of a fine line issue, though, I can imagine, because if you work on this idea of, let me go where have people that have like common interests with me, things that I'm interested in. Well, you might like drinking, and it's
That's
like,
true.
right. And then it's like, well, you go and find people who like drinking,
That's
and you
true.
might end up exchanging one issue for another now, that you
That
kind
is
of
true.
poured into drinking, and that's become so it's one of those things where I imagine it has to be a little bit of a fine line, and I can see how that could be problematic for some. But I think it's emphasis on one of the things that you said, which is like things that motivate you, positively uplift you,
Mhm.
and having enough insight, right, to be able to
Right.
recognize that even if I do like drinking, this is probably not a situation where I should try to find my people that way for at the risk of overindulging and, like I said, creating another issue for myself. Yeah.
Absolutely. I appreciate you saying that. And I think, and also going where I say drinking probably makes you comfortable, right? And so going where you're
Hmm.
uncomfortable. So I think that
Right.
and being un and being
Yeah.
uncomfortable can be in like, all right, now I gotta go in an environment where we're all drinking tea, water, and this is very uncomfortable, but you might find your
Yeah.
support group there. So no, I appreciate that. And you definitely have to
Yeah.
have insight. Absolutely.
Absolutely. Yeah. Absolutely.
If
Gotcha.
I can add
All
a
right.
little bit to that,
Mhm.
typically what I try to tell clients that are dealing with loneliness or isolation and stuff like that, I always tell them that you have, in order for you to get out of that situation, you have to do the opposite of it. So if you're dealing with a lot of major depressive symptoms, I always tell them like, well, if you feel like laying down all day, you don't want to shower, you just got to push yourself to do the opposite until you start feeling comfortable doing the opposite, where you can get over some of those situations. And there's also things like clubs, like video game clubs, online, or you could do church, or you could do something I got into within the last 5 years that I loved was I ran my first 5K maybe 5 years ago. And then ever since then, I fell in love with 5K. And then I started joining some of these running groups. And you wouldn't believe, like, when you search to see, okay, is there any running groups around me? And then to the point where I even brought back like an event to our chapter. So we ended up doing a 5K with our fraternity chapter because I had liked it so much, and I created a program where we can raise money for different scholarships using what I like, which is or my new thing that I like, which is started jogging and stuff like that. So it's just a matter of getting yourself out of that cycle, just think about some of the stuff that you like to do, and then try to see what's near you in the community and do the opposite of what you're doing.
All right. We got another question here. So, for the married or the dating guys, what do you share with your partner versus your boys versus your therapist? How do you split it all up? I've heard mixed results and I want to learn. So, it sounds like it's a question of compartmentalizing, which I think men are yeah, I think men have to deal with a lot, probably because of this whole concept of like, wearing different masks and, the vulnerability that you choose to take on, and in different circles. So, how does one navigate that a little bit as far as like what they say to who, or should that even be a thing? That's kind of the question.
Well, I think first, just those three parties, your therapist, everything. You
Yeah.
can't you can't expect your therapist to be able to give you good guidance if you're telling part of the story. You have to remember that you should be in your therapeutic relationship with someone who you trust, has your best interest in mind, and is giving you what you need by way of whatever modality they're using and the conversations that you're having. You should be able to go in there and be an open book. Like there should be nothing's off the table. When I talk about nothing, I mean apps. Sometimes I sit at my laptop. I love when my clients are comfortable to talk to me about everything, because I'm like, okay. I'm like, no, 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 I'm not offended. No, please go ahead. Tell me more. I mean, that is why I'm here. So, good, bad, in between. So you want to tell your therapist everything. Your partner, though, if you're in a relationship, you're married, you're in some type of, romantic relationship, you should trust that partner to tell them, a lot of things. You have to also know your partner, right? So you know what you can and can't say, or maybe how you can and can't say it. And if you don't know what you can and can't say or how to say, run it past your therapist. And so then let your therapist help you decide what you share and how to share it if it's a touchy issue. If it's something with your boys, just like your family, you don't have to tell your boys every single thing. You should have some friends around you that you feel comfortable with and being 100% vulnerable with without, fear of, jokes or just making you feel less than. So yeah, I always, I say if you don't have one person who you can tell everything to, then you got to find you at least somebody, because what we like to see when you come to therapy is that you have what we call protective factors. And protective factors are generally things you do, whether it's being engaged in. Even coming to therapy is a protective factor, but it could be your being engaged in work, being dedicated to your family and your kids, having good depend on if I'm not available. If you need to talk to somebody really quick, if you don't have, your copay, who can you talk to? Because I do some things for free, not a lot though. So, you need to have people around you that you trust. So we talk about how to build communities that are in our best interests. But absolutely, I think there has to be a very clear line and that you respect boundaries, because I don't believe that everyone should know everything, because everyone doesn't have your best interest in mind. But that's up to you to kind of discern that, and that, knowing who your friends are and who your partner is. Because if anyone is weaponizing something against you, then there's some work that needs to be done in that relationship.
So here's one. Could you describe any access to care, barriers, or disruptions you foresee to mental health care resource services due to disinvestment in this particular area? And I would like to engage Brother Spence maybe in this question too, because is it my imagination or does it seem as though there are less psychiatric hospitals? Are they closing? And so, like in talking about these resources and allocation of resources, obviously, everyone, but just again, given the perspective that you have, I'm curious what your take is on that too.
So anecdotally, I'll answer it like this. Since I see a lot of veterans, let's talk about the VA system. What the reason why we have the unit that system doesn't have the hospital beds to see their veterans. So there's a spillover. There is there is a high demand for inpatient hospital beds. When I speak about demand, you gotta approach it from two things. One, the physical structure. Two, the actual labor force that is going to watch and is going to monitor. You also have to address the ability of the labor force, meaning also psychiatrists, nurse practitioners who are actually going to take care of our patients. I can speak to the fact that I happen to be in North Carolina right now, and one of our county hospital is building a 200 bed psychiatric only hospital in the area, and that is to address the growth of the area. So so the long and short of it is, in areas where across the country where there's population growth, yeah, you see building of new psychiatric facilities. There's a big industry behind psychiatric healthcare. There are a lot of investment funds and private equity groups that own these hospital organizations that are building. Some areas are losing, in areas that are losing population, you'll see decline in beds, but in general, there's a high demand across the board.
Saw something pop up on the chat. Let me see. Speaking of what Black people are going through, have you seen an uptick in mental health challenges in the past year based on how our people have been directly, either employment loss or insecurity, or indirectly the general socio-political climate affected? So, with everything that's going on in our country right now, have you been seeing a lot more people dealing with mental health issues, seeking guidance and help? Particularly those who have been affected by employment. We hear about this all the time, a startling number of Black women, especially, who have lost their jobs, these kinds of things.
I can
Uh,
answer it. Go ahead. Go ahead.
I would say one of the things is that I'm a Generation X. The generations before us, they're doing a better job in seeking care and seeking and going to therapy. So from that standpoint, increasing seeking services, and therefore you're having more practitioners being built through the pipeline. So short.
I was just going to answer it from because I've been doing mental health and crisis management in the prison system in the Florida Department of Corrections, and I can tell that there's a higher uptick now with young Black men seeking mental health services within the prison environment. Because I've been working on and off for about 19 years, and I can tell you in the very beginning, when I first started working in mental health inside of the Florida Department of Corrections, there wasn't a lot of Black men within the prison that sought treatment. And I could say nowadays, there's a lot more that their parents, their mother, sister has been encouraging them to say, hey, write an inmate request, write a sick call request to mental health. I think you need to talk to somebody because I guess some of the times they'll have problems with other inmates or have problems with the officers or just the system in general could be real frustrating. I can say just from inside of a prison environment, Black men has been seeking a lot more services that I can tell as of late.
Yep, I agree. I've seen lots of Black people come to therapy with issues, especially at work. If they work in largely white spaces with a lot more complaints of microaggressions, just people being a lot more openly biased and, you know, just the systemic issues that we knew that already existed, that they seem to be exacerbated by everything that's happening out in a lot of spaces. And I have clients who are federal government employees, persons in higher education at, very prestigious R1 institutions, and I have clients who work even at, even community levels that are they're coming with very similar experiences, especially Black women, in spaces where they are having to experience microaggressions, but then turn around and people expect Black women to be the nurturers, also of certain things, which, there are lots of reasons, Black women have been seen as nurturers a long time from slavery on up, been nurturing everybody, everyone's, even master's children, along with everyone else. So sometimes being thrust in roles because of what people's ideas are that they should be. There have been a lot of people who are just at this right now. They're tired of code switching. They're tired of being strong Black women. They're tired of being strong Black men. People want space to just exist and to be. And so I have seen a lot more people willing to speak or, kind of step out from where they had normally tried to kind of, as Dr. Young said, kind of wear the mask. So now that they're uncovering it, it is a lot different. It's a lot different because Black people are taking their mental wellness a lot more seriously now, I think, than I've seen in years past.
Yeah. So, just as a reminder, now we are due to wrap up. We have about 8 minutes left in order to end at 8 o'clock. So, I do see three questions here. We'll see if we can get through those. But just as a reminder to everybody, this has been a fantastic conversation. Really appreciate everybody chiming in. So, I'm actually going to tackle this one along with you all, just because I can see that there is, sort of a medical bend to this, like MD medical bend in that sense. So, my PCP recently referred me to a neurologist based on some recent, more acute issues with restlessness, frequent headaches, loss of focus, and temporary balance issues, etc. What are some specific questions I should ask the neurologist and/or specific information I should expect to receive that ensures that I am getting the right diagnosis and possible treatment? So, I think this is actually kind of an interesting question because a lot of people don't recognize that there is a lot of overlap between neurology and psychiatry, which, goes hand in hand with mental health. In fact, in medical school curriculums, the two are taught together because there's a lot of overlap. And that being said, there's a lot of overlap, period, with how you're feeling mentally and how that may manifest in your body physically. So, it's not far-fetched to consider this question or ask this question, because I think that when you don't realize that, people are sometimes surprised when they go to their medical doctor, whatever specialist it may be, and they walk away with a psychiatric or a mental health diagnosis. And that can sometimes cause you to feel like you're dismissed, when in fact, the reality is there can be a lot of overlap. So what I would say as a doctor, but not a mental health provider, is, I think, one, just make sure that you feel like you're being heard. Make sure that you feel like you have an opportunity to truly explain the symptoms that you're experiencing, and that those are being received. That you're not being cut off. You have a chance to fully express yourself, and that you feel like you have a connection with that physician. I think that people often feel rushed and not heard. And generally speaking, you can figure out if that's happening. And similar to what has been mentioned before, if you feel like that is happening, then don't give up on yourself or your diagnosis. Simply find a different clinician. But I would say that, going into this, that is, those are going to be the key things you're going to want to try to figure out. Are you being heard? Are you having a chance to fully express yourself? Do you feel as though you're being dismissed? But I would also say, keep an open mind to what may be suggested, because as it turns out, there can be overlap between physical symptoms and psychological or mental health things. And some of the things that have been mentioned here, like restlessness and frequent headaches and loss of focus, those are things that can actually be symptoms of mental health conditions. So that's not to say that that's what's happening, but it's just to help you to understand that that's why sometimes it does require having an open mind about what you're being told. And I think that we all have some level of intuition. And so if you feel as though your intuition is telling you that that's right or not right, go with it to some extent. And certainly, consider seeking out someone else to kind of verify the things that you may have heard. But from a mental health perspective, given that overlap, do you guys have anything else to add?
I kind of want to tag on this, Dr. Young, in that we have to think that mental health is a treatment system, or you can have mental health challenges across the lifetime. And that's why when we train in mental health as nurses, there's childhood specific problems, there's young adults, adolescents, yes, and also the older adult. I mean, I can talk about this a little bit from what I've seen in my family, is that, and some of us have seen it in our own families as well. Um, Closer to in the older adult, yes, neurological symptoms, i.e., dementia, may mask itself as depression. Um, it may mask itself as extreme anxiety. And that's where the psychiatric piece comes in. I think one of the things we have to encourage people to do is just kind of just address the symptoms. I think the big stigma is people don't want to be labeled, but it's not about being labeled really. If somebody can fix or address your issues, then that's what we're trying to get done. We're trying to solve the problem. So, addressing symptoms and getting people better is the bottom line.
Yeah, absolutely. Okay, well then at this point it's 7:58, so I think we're going to have to entertain one other question, and in order in which they came, it would be the one that came from the chat, which is, as men, we're often conditioned to be the rock for our families and communities. When you are everyone else's support system, how do you open up and find support for yourself without feeling like you're falling or failing in your role?
To tag on that, I think you have to use the resources. Um, Dr. Weaver mentioned it earlier as well. And, first of all, most jobs are most employers have EAP resources. most insurance companies or more insurance health plans, which I think we don't utilize the mental health services that our insurance plans offers. And a lot of times, if we actually look at it and look at the resource that you have with your health insurance that you can seek confidentially, it's probably a lot of services that you don't know that you have, and it just takes going to that therapy and kind of stepping out and actually seeking that confidential support system that's out there. It's more, a lot of it is more, it's more than what you think. If somebody is needing help.
And real quick, I just wanted to add too, I think it's changing your mindset, and that can be difficult at times, especially as a Black man, in the sense of perspective that you're human just like everybody else. You bleed just like everyone else, and giving yourself grace, and that you can't continue to be everyone else's support system and be at 100% when you're not. Ultimately, you're gonna, fail everyone else because your cup is empty. And so you have to make sure that sometimes we do have to be selfish, but in a good way, in the sense of setting up boundaries for ourselves and those people around you, your loved ones, if they respect you, they're going to respect your boundaries. And you're doing that so that you can continue to be that support system, right? But you got to make sure that you're doing that for yourself too, and giving yourself grace that even though you have been conditioned through, generational family, how our families have, raised us. I think it's important to remember that you can always stop the cycle. You don't have to use the excuse that, well, this is how I was raised, this is what we do, but the cycle can always stop with you. And just reminding yourself and changing that mindset is going to be the most important thing, and just having that self-awareness that you're human. You're human just like everyone else. And if you are a Christian and you believe in God, that God made you just like everyone else, and it's okay to ask for help. So
Well, with that, I will say that we will come to a or this comes has comes to a has come to a conclusion. Excuse me. And thank you so very much. I just want to give, like, I know it's not quite the same as being there in person, but to give a round of applause to each of you as our panelists. Thank you for providing your insight. Thank you for providing your time. I think that this has been very helpful for us, and really, I just want to accomplish the goal of increasing awareness, because it's the kind of thing that I think we need to be talking about more. And now having a month that is dedicated to this gives us that opportunity. So thank you to each of you for, as I said, your expertise and your time tonight. And for anyone, some of our panelists are local, some of them are not, but they are a wealth of information. And so if anyone here is interested in being able to connect with them professionally, then reach out to us through Xi Alpha Lambda, and I'd be more than happy to pass along contact information for them. As was mentioned, some of them have YouTube channels and are on social media and have companies. And so, just a wealth of resources. And we just thank you very much for everything that you provided for us tonight. And, to those who are participating, spread the word, be a shoulder for somebody to lean on, if they need that listening ear, and to be able to, direct somebody to sometimes just be the sounding board or the voice of reason, to be able to direct somebody to go and get help if they need it. Because we need more of us around, more of us strong in will and mind, in order to be able to accomplish all the things that our life has for us. So with that, I will say good night. Thank you again, everybody. Take care.